Ladies and gentlemen, dear friends, dear colleagues, as president of the European Society of Gynecology, I am happy to introduce you to that fantastic webinar on conservative management of low-grade lesions caused by human papillomavirus. This event is sponsored by ProCare Health, and I thank them for the support they have given to us in this fantastic topic. As this afternoon, we will be together with two speakers, Dr. Fernanda Santos, first from University of Coimbra, and Dr. Damian Dexeus from Barcelona. And it's my pleasure to introduce, first I will introduce Dr. Fernanda Santos, and I will introduce later on Dr. Damian Dexeus before his talk. After both talk, we will have our question and answer session, and you can write your question in the question and answer. You have a special button, you can write your question, and I will read for you, and I will introduce the question to our speakers. And today we have first Dr. Fernanda Santos. She is Fernanda Patricia Autunes Santos. She's a specialist doctor in gynecology and obstetrics at Coimbra Hospital and University Center since 2018, and assistant professor of the Faculty of Medicine at University of Coimbra since 2022, and researcher of the Center for Research on Environment, Genetics, and Oncobiology since 2022. She's a very clever scientist. She supervised and was a jury member of several dissertations for the Integrated Master in Medicine, and she received 7 awards, attended more than 50 training courses, and published several articles, most of them on HPV infection, which is the topic of our today webinar. And she works in medical and health science with an emphasis on colposcopy and pathology of the lower genital tract and gynecological oncology. Then Fernanda, you have the microphone. You can share your screen with us, and we will hear your presentation. Thank you.
First of all, thank you for this amazing opportunity to be part of this interesting webinar that we'll talk today. It is an honor to be part. So it was asked me to give you a little introduction about conservative management of low-grade lesions caused by HPV. This is my table of contents. I start with a briefly background, then we talk about some guidelines, some factors associated with HPV persistent, and then we'll end with some important points. As we all know, the uterine cervical cancer remains a major public health problem with a significant number of new cases and deaths annually globally. The persistent human papillomavirus infection, particularly high-risk genotypes, is the most common cause of cervical cancer. It is undeniable that high-risk HPV infection is essential for cervical cancer formation and progression, but not sufficient alone. Moreover, a lot of drivers have been identified, as you can see by this graphic. There are viral factors, there are host factors and behavior ones, such as multiparity, the sexual behaviors, and so on, that we'll speak a little more at the front. Then, based on this knowledge that more than 90% of cervical cancers are related with a persistent high-risk HPV infection, in 2018, WHO launched a global strategy to eliminate the cervical cancer until 2030, which means to achieve a threshold of 4 cases per 100 woman years. For that, all countries should achieve this 90-70-90 that it is known for us. So we have to achieve 9% of girls fully vaccinated against HPV by the 15 years of age. 70% of women should be screened with a high performance test by 35 and 45 years of age. And 90% of women identified with cervical disease should receive treatment for precancer lesions or invasive cancer. Our presentation is based on these last 2 points. After a correct screen, we have to have knowledge about the scene. It is essential. Who have to know the high regression rates that are related with the low-grade regions, and that conservative management should be or could be an option, and that we should avoid overtreatment and optimize the guidelines for management of SIN. It is important to understand this clinical course. Based on this, I bring to you a recent systematic review and meta-analysis that was published in 2021. It tried to replace the critical review that was published in 1993 by Oslo. Some guidelines are based on that. But this natural history bring to us firm conclusions related to SIN1 and 2 legends. They included more than 8,000 people, women, that were followed at least through different points, 24 months and some for 54 months. And they concluded that at the end of 24 months, 60% of SIN1 regressed to normal. And during this follow-up, only in 2 cases in 7,000 women developed a cervical cancer. They analyze by subgroups, and they conclude that most SIN1 and 2 will regress spontaneously in less than 24 months, with the highest rates naturally in the high-risk human papillomavirus negative and young women, whereas progression to cancer is less than 0.5%. So conservative management should be considered, especially in fertile women and with expected high compliance. Different societies have published the most recent guidelines. In 2019, the American guidelines were published and updated on last year. Canadian and Spanish and also the Portuguese ones were all published. What is different from the previous ones? Actually, the new data indicate that the patient's risk of developing cervical precancer or cancer can be estimated using the current screening test results, but also it has to be account the previous one, the biopsy results, and some personal factors such as age and immunosuppression. The American followed more than 1.5 million women for at least a decade and reached a threshold of 4%. They conclude that a woman with a mediate risk of SIN3 plus of 4% or higher has indication to colposcopy. The Spanish ones highlight the same guidelines. They reach 5%, but they are very similar, just different. The American state as possible to avoid colposcopy when the risk for SIN3 plus is 60% or higher. Conditions, for example, when they have an high-risk HPV infection with high-grade reflex cytology. But this is just one example. Let's see some examples based on this of low-grade lesions. When you have a normal cytology, we all agree that if we identified a 16 or 18 HPV positive, it has indication to colposcopy. The immediate risk is higher than 4%. When the woman has HPV non-16-18, but with a previous HPV test, it also has indication for colposcopy. Although when the HPV is non-16-18 and the previous no HPV test, it is safe to repeat the test after 1 year. And when we have a low-grade reflex cytology, if we have 16-18 or if you have non-16-18 and previous HPV positive, it has indication for colposcopy. If you have a non-16-18, it is safe to repeat after 1 year. But let's think, if after these results we achieve a negative test, it is possible to release this woman for a routine screening, which means HPV each 5 years. Let's see. I bring to you this Dutch study that follows more than 10,000 women for at least 14 years, and they conclude that the immediate risk of a SIN3 plus in a woman with a previous HPV test was higher, as you can see by this yellow line, compared with those that never had an HPV positive test. So they conclude that a previous HPV test or a co-test based on the HPV result give that woman a risk that should be maintained on a screening based on a 3 years interval. This is similar to what is proposed by the American guidelines. But let's look again for these low-grade lesions. When we have a pre-history of a low grade with a colposcopy and the biopsy with a low-grade lesion, and now an HPV positive with low-grade cytology again, the risk is under 4%. We have to repeat it and we have to assume this position of a wait and see. And what happens in the cervix during this wait and see period? Different things could happen. So an HPV positive could be completely cleared, and after 1 year, we will have a negative HPV test, or the HPV infection could persist in an active infection, and when we repeat the test will be positive, or on a latent infection, and we'll repeat the tests and the test will be negative. So this gives us again the impression that we should follow a woman with a previous HPV positive test on a different way from those that never had a positive HPV test. And what factors could contribute to this persistence of infection or persistence a low-grade lesion? Based on what we talked before, we have viral characteristics that is important and host factors that we will highlight. Let's start about genotype. Looking for numbers is always the easiest way. So this group made a study which include ladies with low-grade lesions and follow them for 2 years. And what they conclude? They conclude that when that woman had HPV 16, the persistence was the highest for the SIN2+, 32%, but when the HPV genotype was non-16-18, the progression was only 5%. So genotype matters. What about viral load? Viral load is another issue that is being studied a lot. And I bring to you a study that included 800 women with low-grade lesions or a normal biopsy that were followed during at least 2 years. And as you can see in this table, when they had a low viral load, the clearance of that HPV infection occurred in 40% of cases. But when the viral load were high, the HPV persists for at least 40%. What about the host factors? Age, it is something that all we know that is related with the immune system, and it is easier to conclude that the age matters. On the same study, as you can see, women under 30 years, only 8% persist an HPV infection after 2 years of follow-up, but ladies with more than 60 years, 12% persisted. So age actually contributes to the persistence of HPV infection. What about vaginal dysbiosis? A huge amount of studies have been published about the connection between the vaginal microbiome and the vaginal host defenses, specifically against pathogens such as high-risk HPV infection. Based on next-generation sequencing, many human microbiota studies have identified complex microbial communities in healthy women. Ravel et al. Investigated 5 community states that you can see by this picture that are dominated for different types of lactobacillus species, or does not have lactobacillus, such as the community state type 4 that is connected with bacterial vaginosis. And they also conclude that this environment is also influenced by different factors such as ethnicity, genetic factors, the diet, the gut microbiome, and other factors such as sexual behavior, hygienic practice, and so on. Particularly, it is also important to highlight that lactobacillus abudensis changes by level of glycogen, as you can see below. And prepubertal girls in postmenopausal women have relatively low abundance of lactobacillus species. This could be one of the reasons why a menopausal woman could achieve an HPV infection more easier than a non-menopausal woman, and that infection could persist for more time. There are an interplay between vaginal microbiome and epithelia and the immune defenses, as you can see in this picture. The community state type that is dominated by Lactobacillus crispatus is associated with the protection against pathogens, including high-risk HPV, as you can see in this picture, and high-risk HPV infection clearance. In this community state type, the cervicovaginal microenvironment exhibits an anti-inflammatory state, allowing for effective immune responses against high-risk HPV and the disruption of its viral life cycle. Studies relate this community type without progression for a disease state. Although, if you can, as you can see, the community type 4, it is related with persistence and carcinogenesis. Looking into more detail, in a normal cervix, we have abundant microbes based on lactobacillus. We have an intact epithelium, as you can see, with an acidic environment, and we have also an intact immune cells based mainly in this scheme by innate immune cells. If we have a persistent HPV, the microbiota is different. It is decreased on Lactobacillus crispatus or gasseri, the good ones, and as other gram-negative and positive bacteria. The epithelium is disrupted, the pH is high, and the immune state is suppressed. Again, based on a study that it looks for me very interesting. This group follow a group of women with SIM2 plus lesion during 12 years and relate the regression or persistence based on the lactobacillus component and the community state types. And as you can see on the green one on the left chart, the regression was high when they have a dominant lactobacillus microbiota, and there are more non-regression related with the community state type 4, as you can see at the end of 12 months. So, higher diversity with lower lactobacillus content has been associated with increasing severity of SIN, as you can see. The lactobacillus species depletion can lead to this dysbiosis, which will conduct finally to the cancer development. It is related with a pro-inflammatory environment that could culminate in an invasive disease. So many authors argue that the cervical vaginal microbiome can potentially be used as a biomarker for cervical disease and SIN development after high-risk HPV infection diagnosis, with implications on cervical cancer prevention strategies and treatment of SIN. In this context, based on this, bacteriotherapy has emerged as a promising platform for HPV infection treatment and HPV cervical cancer prevention and even treatment. Some examples of bacteriotherapy are the probiotics that may become the best choice for controlling the complex interaction between this microbiome, HPV, and the carcinogenesis, and also the vaginal microbiota transplantation. It is an emerging experimental intervention. In this picture that I bring to you, it was taken from the published study that was published in 2019. about the study of 5 ladies with a bacterial vaginosis, symptomatic and resistant to all different types of treatment. They have done a vaginal microbiome transplantation based on the same criteria of the fecal microbiome transplantation that is approved by the FDA since 2012. And they confirmed by this wet mount, as you can see, that they achieved a normal microbiota and they are all symptomatic. A lot of research is being done on this. What about the epithelium? Cervical ectopy is a benign condition that we all find on our appointments. Rarely it is symptomatic, but when we have symptoms, it manifests such as leukorrhea, bleeding, and recurrent vaginal infection. I bring to you a study that include ladies with a symptomatic ectopic cervical ectopy, and 40%, more than 50% had an HPV, and this was also related with higher microbiota diversity and a pro-inflammatory state. Lastly, the psychological impact. We all know that an HPV test brings a lot of anxiety, distress, and stress, and this was proved and published by a recent meta-analysis. It is also related with disgust, shame, surprise, and fear about cancer. And we all know the impact of stress on the development of some diseases, and the cervical lesions are not an exception. By this diagram, you can see that stress that could lead to high levels of norepinephrine could have a direct impact on the vaginal epithelium, related with low levels of antimicrobial proteins, culminating in a dysbiosis, dysregulated immune response, and high pro-inflammatory state. The same could be achieved by cortisol levels that are related with a reduced in lactobacillus species and lactic acid, high levels of pH that could lead into this dysbiosis. This is important because we all should take some minutes to talk with our patients in order to explain the real meaning of an HPV positive test and try to reduce a little bit the stress. This could be very important for the treatment success. So, highlights of my conclusion. Infection with high-risk human papillomavirus is a necessary cause for cervical interepithelial neoplasia, but not sufficient. To avoid overtreatment and optimize the guidelines, it is important to understand the clinical course of SIN gradation. We have to know that this SIN has a high regression rates of 70-90% within 2-3 years. The current cervical cancer screening recommendations are based on risks and not on results. The conservative management is considered safe for SIN 1. During the wait and see, the HPV infection could have different behaviors, could be cleared or persist in active or latent states. And there are some factors that we know, and such as the viral characteristics and the host factors that have to be taken into account. And that's all. Thank you for attention, and I hope that you enjoy.
Thank you, Fernanda Santos, for the beautiful presentation. We will have a lot of discussion later on. And now I will move to the presentation of Dr. Damian Dexeus. He's a precision specialist in gynecology and obstetrics. He has more than 15 years of experience in the profession and extensive training in different fields of the specialty that made him a great expert in obstetrics and maternity, with a special interest and study of premature babies, HPV, gynecological cancer, and breast cancer. Through his career, Dr. Dexeus has combined his healthcare work with an important research and informative activity, being a regular speaker at congresses of the specialty and author of scientific articles. He is currently medical director of Women's Health Institute in fantastic Barcelona. Damian, you have the microphone. Please share your screen and make your presentation. After the presentation, we will have the discussion on both of them, and I invite all of you to write your question in question and answer area. Thank you. Please, Damian.
Thank you very much. I think Fernanda has done probably 90% of my job, and that is by justifying basically why we started with all of these studies. You've already seen this picture. I mean, we all know, and this is a classic discussion, and we all understand that the wait and see attitude is necessary, and that's something that we have to consider. Despite that, we also know that not always the wait and see attitude is well accepted by our patients. So they demand for us to do something else. And that's where we wanted to try and see if there was something that we could do, or there was something that we could be able to help with. You've already seen a bit of this, and this is the definition of Coriolus versicolor vaginal gel. Basically, these are the ingredients: hyaluronic acid, beta-glucans, Centella asiatica, biocholia, neem, and this incredible substance here, Coriolus versicolor. So basically, the aim of what I'm going to show you is try and demonstrate and try to give you some idea of why we started this, me obviously, and the whole of the team of my colleagues that are enrolled in all of these studies. When we first heard about the Coriolus-based vaginal gel, we thought, okay, that's great. That's something that we need to test. So before doing anything especially big, let's put it that way, we wanted to conduct a very tiny pilot study. And when I mean tiny, I mean 21 patients, just a 12-day treatment with the vaginal gel, and see what happened. Again, it was basically to see if it made sense to really push it a little bit further and go for more studies. So this was published, and the results were interesting in terms of both epithelialization of the cervix and improvement in terms of vaginal health and microbiota status. Again, very short study, so clearly we needed to move a little bit forward. Instead of doing just the 21 patients for 12 days, then we moved to this also pilot study that was epicervix, basically conducted by our colleagues in Luis Serrano in Madrid. Instead of just doing it for 12 days, what they did was using the same product for 21 consecutive days in 21 sexually active HPV positive women, all of them aged 24 or more, with a negative cytology and normal colposcopy. What we measured there was what was happening with the microbiota. We used the Shannon index in the beginning to see what was going on, and if we were capable with this very short period of time, if we were able to make a difference. And these are the results. Please remember, high diversity is not good news in terms of vaginal microbiota. And when you look specifically at those two components, Lactobacillus crispatus and Gardnerellas, there was an interesting shift there. So we had more colonies of crispatus and decreased colonies of Gardnerella vaginalis. To be honest, I don't know if you're seeing my marker, but we don't know what happened with this concrete patient. But this is what we found. This is what we published. So we felt that it probably made sense to push it a little bit further on. So we then designed this first clinical trial, and this is the Paloma trial. It was a huge effort, and all of the studies always are a huge effort, obviously. But when it came to designing the study and having absolutely no experience whatsoever with Coriolus versicolor, we didn't really know how big the size of the sample should be. We had a few doubts there. So probably if we had to decide, or if we had to design again the study, we would change a few things for sure. But this is how we designed it at that time. And this is what we did. We did. Primary outcome, primary objective was to see what happened in terms of repairing this low-grade lesions. Secondary endpoints were basically clearance, vaginal health, stress, satisfaction with the product, treatment adherence, whatever. Please remember that this was conducted with Procare, with the industry. So the patients were given the product. Okay, the sample was designed for 101 patients. Mean age was 41 in the treated groups, 41.3 in the control group, 39.2, so pretty much the same. When it came to the percentage of high-risk HPV patients, because in this study we also recruited low-risk HPV patients, which now we know it didn't make too much sense, but that's what we did at that time. In the treated group, we had 75% of high-risk HPVs. In the control, 75.7. The design of the study was always to perform colposcopy, cytology, and an HPV test in the month 6 and 12. Obviously, also when recruiting these patients. All of the samples were sent to a central lab in Oviedo, and what we did was 3 different arms, 2 different schemes of treatment. Scheme A was on a daily basis for 1 month, skipping always the menstrual period, the 7 days that we would consider normal for a menstrual period. And then we switched for every other day period for 5 additional months. Then scheme B was again 6 months, but a 3-3 scheme, meaning this that they used it on a daily basis for 3 months, and then alternate days every other day for another additional 3 months. When I present to you the data, we will be using both schemes together. We didn't have enough strength to give the results if they were separate. Okay, so when I give you the results, when I show them to you, you will be considering both treatments together. Obviously, we had this control group in which we didn't do anything different. Obviously, we kept the same timetable. We kept controlling as the treatment group, but they were not given the medication. So this is what happens when it came to, and I'll always talk about, again, high-risk HPV population. Didn't make too much sense to give you results of low-risk HPVs. When it came to repairing lesions after 6 months of treatment, these were the results. At 3 and 6 months, you can compare here the results. Control group was 52%. Papillocare group of treatments was 80%. When we moved to 6 months, then we had a little difference there, 56 in the control group, 88 in the papillocare groups, in the groups that received the vaginal gel. So that was interesting. That meant that there was something going on. There was a little bit of a difference there. Interesting, just put it that way. When we checked what was going on with the high-risk HPV clearance rates, we found a 40% in the control group, which, to be honest, was a bit surprising. We weren't expecting such a high rate. We were expecting something closer to 30% if you consider other publications such as Bugman's publication. But nevertheless, this is what we found. So this is how I showed to you. HPV clearance, and that was measured at 6 months, 40% with the control group, 63% in the treated groups. These are the changes. So this is the increasing rates, 28 and 32% in the different groups. You heard from Fernanda, stress, surprise, fear, disgust. All of these are items that are usually couldn't say not considered, but difficult to measure. Okay, we tried to do that, and we tried to measure what was going on with the stress measured with the PSS 14 scale, and these were the results. A slight better result with the treatment groups. That was something that hopefully we had to see and we were expecting. Maybe we could have seen something a bit better in the control group because they were being followed on a regular basis, but these are the results. So again, if you take a look at the big numbers, 58% of the patients treated with Coriolus versicolor-based vaginal gel improved the level of what they perceived as stress. 93% had a correct adherence to the treatment, so they followed correctly the treatment, which was something that we were expecting because we gave them the treatment. So if they had to pay for the treatment or if they had to follow it in a different manner, it would have been maybe a bit different. 87% of them reported to in some way, in some degree, some satisfaction. None of them were dissatisfied. When it came to complication or complications with the treatment, we considered that we had 7 related to the treatment. 6 of them were considered mild or moderate in severity. So that meant basically itching, stinging, but not a huge adverse effect. This meant at some point in 3 cases that they had to stop using the vaginal gel, in 3 of them. One of them finally decided she wouldn't continue. She couldn't cope with this sensation, so she left the study. No serious treatment-related adverse effects were found. We had a patient that had breast cancer diagnosed in the interval of the 2nd and the 3rd visit. So obviously she had to quit, and she had to go to different strategies, obviously. Let me show you this, because this is when we did this sub-analysis, and we wanted to see what happened if we just looked at the worst scenario possible. And Fernanda showed you in the previous presentation, age is important. So you have a lower chance of resolving this problem, a lower chance of clearing the infection if you are a bit older. So we wanted to check what was going on in patients aged 40 or more. And these are the results. All of them have been published. You have the references here. And this is what happened. When it came to regression of the cytological lesions in high-risk HPV patients, these are the results. If you look just at the whole HPV group, here are the results: control group 50%, papillocare group, treatment group 92%. If you go and look just at the high-risk HPV subpopulation, defining high risk, you know perfectly, but we included all of these viruses. The results were these. Control group went to 33%, and that gets a bit closer to what we were expecting, that 29-30% expected in the Bugman's publication. And in the treatment group, that went up to a 90%. So when testing this product, when testing vaginal gel based on Coriolus versicolor in a worse scenario, it proved to still be pretty effective. Let me move a little bit forward and show you this other study. This was Papillops. Papillops was an observational, national, multi-center, prospective, non-comparative clinical study. We didn't have a control group here. We didn't provide with the medication to our patients, to all the patients that were enrolled in the study. As I said, this was national, only here conducted here in Spain, in different areas of Spain, in different hospitals, private and public, the same as the Paloma trial. Recruited 192 patients from May 18 to February 2021. We had COVID around there, so that made things very difficult and challenging, but this was the final result. Mean age was 41. High-risk HPV positive percentage of patients was 93.2%. Here, we accepted vaccinated women, again, only with low-grade lesions. Let me just tell you something about the Paloma trial, which I didn't comment in the previous slide, and that is just an anecdote. But in the beginning, we accepted in the protocol, in the guideline, to have low-grade cytology smears, meaning that we could have had, luckily we didn't, glandular low-grade lesions. Luckily for us, we didn't have any. That was very good news. In this one in Papillops, we obviously didn't want any glandular lesions because we were using colposcopy, and we knew that might have some limitations. But, and that's a difference between Paloma and Papillops, we did perform biopsies here, which we didn't in the Paloma trial. We didn't want to change anything in terms of the natural history of the infection or in the natural history of those lesions. So we thought that by conducting biopsies, we might change that, and we didn't want to do it. In Papillops, we did have some biopsies, and this is the result, CIN1 biopsies in 56. Okay? So again, primary objective, primary outcome, to see what was happening in the reparation of these low-grade lesions. Secondary endpoint, HPV clearance. The scheme of the treatment was a bit different when compared to Paloma. We had an initial visit in which, if needed or if considered, we could perform a biopsy. We then went into the 6-month visit. We didn't have the 3-month compared to Paloma. We went straight directly to 6-month visit. And then the question was, do we have a normalization of the lesions and or HPV clearance? If the answer was yes, then treatment was completed. That was it. If the answer was no, then we asked our patients if they wanted, and the answer was basically always yes, but if they wanted to consider the possibility of continuing for 6 additional months. The treatment scheme was the A scheme from Paloma, and that means 1 month on a daily basis, 5 months on every other day basis, okay? So some of those patients went up to another 6 additional months of treatment. Let me show you the results. And this is what we found. When it came to cytologic normalization, here you have the charts. Out of 178 patients at 6 months, we had this. We still had 59, which were still positive, out of which they continued to the 12-month treatment, and we only remained with a 14% of still abnormal low-grade cytology. When it came to HPV clearance, we lost 2 patients there because some of the HPV results were not reported. So we had to obviously remove them from the study. And these are the results: 76 in the beginning, 75 at 6 months. And those additional 6 months brought the HPV positive patients down to 22. This means that we had this reduction of 71% of the patients. So again, we felt that this was pretty interesting. And as I said, as done before previously with the Paloma trial, we then wanted to push this a little bit further and see what was going on worst scenario possible. And that is, again, as you saw in the Paloma trial, women aged 40 years or older with high-risk HPVs. When it came to cytologic normalization, these are the figures. Out of 68, 18 remained still with cytology abnormal smear. 5 of them still when we went up to 12 months. So these are the percentage: 74, 81 if we pushed it up to 12 months. When it came to HPV clearance, 60% at 6 months. Please remember, always high-risk HPV and age 40 or beyond, and 60% at 6 months. And if we brought that to 12 months, we found that 74%. So that there basically we had kind of an idea, or maybe something that we wanted to look upon maybe later, and eventually, hopefully, we will be able to do that, is if there's a dose-dependent response in this whole treatment. So we'll see that further on. When it came to final results in the Papillop study, and we were measuring, and that was important for our patients, but obviously for us, in the satisfaction scale, what happened, these are the results. Average 7.9 at visit 2, which meant at 6 months. If they had to go to 12 months, they still found that they was satisfactory to continue with this study. In terms of adverse effects, we found exactly the same as we found in Paloma trial, except that none of them left the study. So that was easier than with the Paloma trial. Whilst we were conducting these studies, please remember both of them, Paloma and Papillops, sponsored by Procare Health. We had a very good surprise, and that is that suddenly some publications and studies were published that had absolutely nothing to do with us. And when I say us, I mean the industry group. And they were eventually published when we were still recruiting patients in Papillops and in the Paloma 2 trial, which I'll show you a bit later on. I won't go over all of them, but just in a very quick way, we saw a few studies both in Catalonia and in Galicia, and there was also a very interesting publication in Rome let me show you a little bit very briefly what we found. And I know that this in a way is cheating a little bit, because it's practically impossible to compare all of these studies, because they were not conducted in the same way and they had differences. But if we just go quickly over all of them and we check on what the results were, they were pretty consistent with what we were seeing and publishing. If you see this one, this is the lowest one, but if you see here, all the other ones had very similar rates to what we saw in papillocare and in papillops. There's a mistake here. This shouldn't be papillocare. This should be only papillops. Okay, so the results and the data published by other groups were very consistent with what we were seeing, and overall 63% HPV, high-risk HPV clearance in 6 studies is I think very consistent. It's just not indicios, however, that's how we say it in Spanish, but it's just more consistent data. This is again, this is the expected clearance rate that we were expecting to find in the control group, as published previously by Bulkmans. But nevertheless, that's what we saw, and that's what we published. This is, I wanted to bring this one up to you because this is the study conducted in Rome, and this has a difference between in terms of the design of the study, because they didn't use the 6 month strategy with the treatment, but they used only 3 months, and the results were still pretty consistent. So that was good news. I won't go over the study. I shouldn't go over the study because it's not ours. But again, consistent data, results very similar to what we had published. Different strategy, different beginning of the study with just 3 months of treatment. But again, interesting results that met pretty well with what we've been publishing until now. What's going on in terms of studies conducted by Procare Health, by the industry? We have still Paloma 2 trial that's pretty much the same as Paloma trial, but only conducted in public health hospitals. And hopefully within a few months, we will start having some interesting data there. There's also Papillocan going on, and we will hopefully again be publishing those data, and that was comparing the treatment with placebo. And now, and I'll just go very quickly because that's not the topic that we should be talking about today, but there are more and more groups testing Coriolis versicolor based vaginal gel in dealing in managing high grade lesions. Always in very selected cases, but it also opens another window in order to maybe test it. It's already been tested. I won't show you the results, but they're again very interesting and consistent. So hopefully we should be considering the Coriolis versicolor based vaginal gel as something that should help us and something that we should offer to our patients when when dealing with wait and see strategy. I think that we've demonstrated how the Paloma study, with the Paloma trial, and 88% of high-risk HPV patients with cervical lesions that showed how they would be able to turn that cytology back to normal. 63% of them had a clearance rate of that HPV with 6 months of treatment. When we looked at papillops results, you've already seen, it was very consistent with what we had already seen in the Paloma trial. When we pushed things a little bit further and we tested both scenarios with the worst case possible, and that was high risk HPVs plus older women. Again, they demonstrated, Coriolis versicolor vaginal gel demonstrated that it was useful. The 6 independent studies were basically oxygen for all of us, because they demonstrated with their studies different designs, but they demonstrated that they were achieving the same figures as we had been publishing. So I think it's fair enough to say that this conservative approach and treatment with the Coriolis versicolor vaginal gel represents a clinical advantage during the wait and see period. And I think that's about it. So thank you very much.
Thank you to you, Dr. Dexeus and Dr. Santos. Fernanda, we are waiting you, and we will start now. We have received a huge series of questions, I will start with them, and okay, and okay, then first, Fernanda, we start with a very simple question, which is, I think, very interesting to be able to follow your response. An anonymous she or he asked, should intravaginal douching be avoided by all women?
This is simply answer yes.
Very important. It's very important because this is a very bad habit that
Yes.
some of them have. And then, Damian, a question for you. What are the main ingredients of the Coriolis-based vaginal gel?
Coriolis versicolor, beta-glucans, neem, niasomes, and I would say that these four are probably the most interesting of all of them. Maybe we should consider some other additional pre and probiotics, but nowadays we feel that probably the most important ingredient there is Coriolis versicolor.
Thank you. And now another question from another anonymous. It is for Fernanda. Can HPV vaccination be given during pregnancy?
Not. Actually, the studies does not include pregnant women, so we should avoid it.
We should avoid it. Thank you very much. And then now I will go on another question to Damian. Okay, I will take that question from Daniel Kapp. In the HP vaccinated patients, were the HPV types found mainly those not covered by vaccine? Were the patients' responses to gel different from the non-vaccinated patients?
No, the answer is no. First answer is I don't know, because we only checked that in papillops in the observational study. So I really don't have the answer to tell you if we saw HPVs that were contained in the vaccine. Remember that population here in Spain, when we started with the vaccination program, it differed in different communities. In Catalonia, we used the bivalent vaccine in the beginning, then we switched to tetravalent, and then obviously now we're with the nonavalent vaccine. So I couldn't give you an answer to that. And the second one was, if there was a difference. Can you go back to it?
Yes, and the second question, I'm sorry, I'm sorry, I have to go back to find that one.
If we saw any difference in terms of the effectiveness of the vaginal gel, could that be it?
Yes.
Yeah, the answer is no.
Okay, thank you so much. And then now, Fernanda, another question for you. What follow-up should be indicated to a menopausal woman when we found a low-grade lesion?
Based on the recent guidelines, we all know that age matters, but it should be the same measure. After one test, HPV positive with low-grade cytology or low-grade lesion identified at colposcopy, we can also assume a wait and see after 12 months period.
Thank you. And then now we have a question from Alice Sorrentino. Damian, thank you for the presentation. I have a question regarding the improvement of lesions on the vaginal gel between different age categories. Just to clarify, did your studies discover a significant difference between reepithelialization of lesion in the studies conducted in different age categories? And if so, what could this difference be attributed to in terms of efficacy of the gel on lesions?
We didn't. We couldn't look at that because the study wasn't designed for that. So the number of patients recruited wasn't strong enough in order to check that issue. We were concerned about that because in the epithermics pilot study, we were only using very young women. So we were expecting maybe a better answer in terms of reepithelialization when using the vaginal gel, but we didn't have enough strength in the Paloma trial with 101 patients in order to check that, because the figures were too similar. So we clearly, if that should have been the endpoint, then the number of patients recruited should have been at least triple. So that wasn't the main objective. I cannot give you an answer. We don't think we should be finding a huge difference, although all of us colposcopists know that the chance of finding cervical ectopy in a woman aged 45, 50, or 55 is clearly lower when compared to younger patients.
Then a question from Rivinda Vitarana, Fernanda. Is having recurrent bacterial vaginosis a known risk factor for VIN3 or cervical cancer?
For VIN3 vaginal?
Yes, for vulvar intraepithelial neoplasia or cervical cancer, to have the effect recurrent bacterial vaginosis.
Yes, different studies connect this vaginal bacterial vaginosis and the highest risk of develop an high-grade lesion on the vagina, on the cervix, but we do not have treatment yet.
Thank you. And Damian, Elena Rota, she's asking, which is the best screening program for over 30 years young women? HPV test every 5 years or pap smear every 3?
Clearly,
nice question, eh?
that's tricky, but that's easy, because at least I can answer in terms of Spaniard doctor, and the Spanish guidelines are very clear. HPV-based screening programs on a 5-year period.
Thank you very much. I totally agree with that point.
Mhm.
And also another one, Fernanda, this is nice also. Do you recommend, this is from Berna Aliloglu Paker, do you recommend high-dose folate supplementation to prevent the recurrence of CIN, of SIN?
I do not have knowledge about that.
And you, Damian?
No, me neither.
Okay, fantastic. Okay, no, it's clear. It's important to clarify the different points. And then
the potential study.
and then Valiat Yolayemi, thank you, Dr. Fernanda, for the concise and well-detailed discussion. Is there added advantage of co-testing over single testing using either cytology or HPV DNA typing only?
Actually, the advantage is only with HPV. It is enough. The different guidelines state that.
Thank you. And then now, okay, this is for Marcus Saschenmeier. Damian, would you offer papillocare treatment to patients with intermediate risk SIN2 and HPV HR plus under age of 40? If yes, how often would you recommend control, such colposcopy or biopsy?
Unluckily, my answer today has to be no. I cannot recommend that, because we haven't demonstrated still with any kind of study the effectiveness of vaginal Coriolus versicolor vaginal gel. If I may, as I showed in the end of my presentation, there are very, very, very interesting ongoing studies and already publications in using precisely Coriolus-based vaginal gel in CIN2 patients. But again, I should be saying no. We haven't demonstrated anything in that area yet, so the answer is no.
Okay, thanks a lot, Damian. And Sonia Molina, she's asking to Fernanda, do you recommend the microbiota genotypification in persistent HPV infection or in persistent low seal lesions or in both?
Actually, we do not have the techniques available. We should do a cheapest way to evaluate the microbiota is a fresh wet mount. This is a possibility until the NGS is available and cheaper. So
I think that's the issue, cheaper, because I wish we could do this in all our patients.
Yeah.
It would give
I
us
will do
such a
it,
huge
yes.
amount of information, but
but we don't. It is very expensive.
yeah.
Yes, and then now we have a question from another friend of us, Serge Quinter from Luxembourg. This is a question. particular. I think, Damian, I will ask you to answer, and eventually, Fernanda, you can add something. He asked, why treat for 6 or 12 months with gel if I can do thermocoagulation or laser in 5 minutes? It's a very important question. It's a very important the answer.
Yeah,
Because
it is.
it's biologically speaking in the destiny of the evolution of the lesion and also in the destiny of the biology of the organ, which is the cervix. Please go on.
It is. Again, what we are trying to do is to be more and more and more conservative in our management. So by doing whatever kind of treatment, cryotherapy or whatever, we are not conducting an expectant conservative way of dealing with these lesions. So we clearly wouldn't do that. I don't think there's one guideline that would counsel you to do this, except in one scenario. If you're not sure that you're going to be able to keep an eye on that patient, or put it the other way around, if you're sure that you're going to lose that patient and you're not going to be able to control her ever again, then go for it, for sure. It's the best way to go. But in our scenario, Europe, Portugal, Spain, we should be dealing with these patients in a conservative manner.
Fernanda, you want to add something?
Totally agree.
Thank you. And then is Yana Rakova. She asked you, hello, Fernanda. For how long would you recommend the probiotics and which type?
There are a lot of studies. We don't know the perfect probiotics, the way to do it, vaginal, orally. We have to wait for more studies, I think.
I think probiotics is the huge problem we are now dealing with. We have tons of them available, but we don't really have any consensus good guideline that can help us then compare results. So that's the big issue with probiotics.
Yes, and then just on that line, Rivinda Vitarana, she's asking you, do you think Paloma trial should have few arms comparing other treatments, probiotic or lactic acid gel, etc., versus papillocare?
I wish. But go and tell the sponsor if he wants to open a 600 patient study with 4 or 5 different groups. We wish we could do that, but we have to be sensitive. I mean, we have what we have, so we couldn't do too much. And please remember this Paloma trial. To be honest, if we had to design the study today, we would change a few things. We wouldn't recruit low-risk HPV patients. We would perform biopsies if needed. We would accept vaccinated women, but that's the way we designed it at that time.
Yes, I totally agree with that point. And then also now for Fernanda, question, safety of papillocare in pregnancy.
I think Dr. Dexeus.
Not officially tested, no publications in pregnant women. So the answer should be no, don't use it. And again, if I may, in my experience I've been using this kind of gel for a long time now. I've been using it in pregnant women with an excellent result. But I know that this is politically incorrect to say that. We should stick to the indications that have been proven with publications, studies, or papers. We shouldn't be using it in whatever manner. So answer, no.
Thanks a lot, Damian. I totally agree also on this point. And then now a reflection from an anonymous, Fernanda. What about setting where the genotype is not available? Would always like to know that the public system would allow the expense.
When the genotyping is not available?
Yes, it's not available because, in some countries it's not easy to have it, and that also the health services, they cannot provide this because they consider this quite expensive for the objective.
I think we have to do a colposcopy and decide based on colposcopy findings.
And then also from Damian, from Bernard Loglu-Pecker, can Coriolis versicolor based gel used with another vaginal treatment agent?
we didn't compare. We didn't do this. We didn't look for synergistic options. We only considered when we used vaginal Coriolis versicolor exclusively. Does this mean that we cannot use different components? Maybe we would find some synergistic opportunities there, but we haven't tested them.
Thank you. And then Svetlana Mavrodi, she's asking, thanking you, Dr. Fernanda, for interesting presentation. My question, why are antibodies not detected after HPV vaccination? And why bivalent vaccine is more effective than other multivalent HPV vaccine? This I don't know, I'm not so sure on that. Can you make a comment on that point?
I think this out of the presentation, okay?
Yes, yes, but, we have
yes.
to answer the question. You're a clinician, and when you go to your
Why,
activity,
but
you
can
have
you
also
repeat
to
it
play.
again? I don't understand why
Yes.
we do not detect the antibodies.
My question is, why are antibodies not detected after HPV vaccination? And this is not true. And why bivalent vaccine is more effective than other multivalent HPV vaccine? And this is also not true.
Not true.
Yes. Then I
It's
agree.
the non-true and question. I think I
Yes.
don't have any comments. That's not true.
Yes, and then that one, Damian, for you is from Caterina Vieira. We have a patient with a positive HPV test and normal colposcopy. Do you counsel HPV vaccination or vaginal gel or both during the wait and see period?
For sure, both.
For sure, both. This I thought that this has to be clear because they are acting in different ways. Please go on.
This has to be very clear. This is not about choosing one or the other. The objective is clearly different. I mean, they're not competing in the same scenario. First thing to be 100% sure about this, vaccination is the way to go. If we had all of our female and boys and girls vaccinated, we wouldn't be talking about anything, probably. So vaccination is the perfect way to go. When what she asks is, will vaccination help me to deal with this HPV currently, now, today? The answer is no. We have no evidence that it will help now. So if what you're asking me is, can you provide me with something that might help me today in dealing with this HPV and bringing up the clearance rates? Clearly, Coriolis-based vaginal gel. But don't forget about vaccination. That will protect you tomorrow and the day after and forever.
Okay. Then another one from Eric Esquivel. Can papillary care be used more than 6 months in the period of wait and see for the clearance of HPV?
Yes, as demonstrated with papillomas. Although the number of patients that had to continue to the 12-month treatment was small, the answer is yes, because it demonstrated that it showed that it might be able to recruit some of the still positive patients by bringing it up to 12. So the answer is, if they're willing to do it, the answer is yes. They might benefit of an additional percentage.
And then Fernanda, from Carmina Vidal, she's asking from Valencia, thanks for interesting presentation. What do you think about treatment of the male couples?
Treatment of the male couples.
Yes. What do you do with the positive male?
Or the positive HPV positive.
Yes.
In Portugal, we not have any test, or I think there are no tests to identify the positive HPV infection in a male. So I always advise vaccination of the couple.
First.
Is one of the things that I do.
Yes. And also for the larynx and also other levels.
Yes.
And yes, because now in the modern time, the people like the ice cream, and then so it's better to take care also of the larynx. Damian, do you have any comment on that point?
No, I totally agree. I mean, again, vaccination is the answer. We wanted to see if we would be able to improve the the treatment rates of genital warts in men by using a Coriolus versicolor-based vaginal gel, but we haven't designed the study yet, although it's something that we have there, and we might in the near future, we might test. But today we have no answer in terms of treatment. Again, I totally agree with Fernanda, vaccination.
Yes, and then Rasha Al-Radad asked, can gel be used for external vulval warts or vaginal?
Yeah, it's been tested. Efficacy is still low in what we saw in our very tiny study. We are again trying to conduct a bigger study in treatment of vaginal warts. So then low grade lesions, low grade HPVs. We will see. The thing is that nowadays we have too much work with what we have, and opening the window of CIN2 and 3 patients, probably benign conditions will be left for the last to be tested.
Thank you. And then now Amina Nagi, she made a nice question. What is your opinion in low seal with high-grade HPV 52, 18 positive? Do we proceed for a colposcopy, outpatient, or colposcope and let's straight away?
Mm. If I may answer that?
Yes, any of you.
100% colposcopy.
Yeah.
Always. I mean, I know Italy, Portugal, Spain, we are a very colposcopist schools. I know, and we feel very comfortable with colposcopy.
With colposcopy, yes.
So I would always recommend colposcopy.
Okay, then another question. This is also to you know, we have also that concept of the importance of the vaccination. This I strongly believe on that one. And Donata Kakori, she asked, do you think that anti-HPV vaccine helps get clear from HPV at women that are HPV positive, not just help to prevent infection?
I'm afraid that this has already been hugely published. Therapeutic effects of the vaccine have never been demonstrated. It's just a prevention strategy. So the answer is no.
This is unfortunate, but it is true.
Hopefully it will change.
We have several other questions on papillo care, if can be used in pregnant women. And you tell that we don't have yet the study done, because it's not that we can't, but we have not yet the study
We have
done.
no publications.
Yes. Oh, then another question from Merv Olgun. First of all, thank you for the wonderful presentation. I want to ask a question to Fernanda Santos. How can we provide vaginal microbiome better than for protecting to HPV? What kind of diet do you recommend for that?
About the diet specifically, I don't have an answer. Okay. There are studies that have been published about the Mediterranean diet.
Living in the middle of Mediterranean, as in Italy, I am totally in favor of that one.
Absolutely.
A good life type. We have to be healthy. It's just that I don't have a specific answer for that, okay, about the diet and how to measure how it is always related. There are a lot of studies, but we have to see the things as a whole. Okay, we have to.
Tricky question.
Yeah, tricky question completely.
Okay, Yana Rakova, I have seen your question, and then I will be in touch with you. This was something for another point. Then Mariani Anguladze, she's asking if CHIN1 have spontaneous regression values in most cases, why do you think that papillo care is a cure? It is completely possible because without, okay, then the question means that certainly you also mentioned that already in some patients we have the disappearance of the hairly lesion. Can you be more precise on that point, Damian?
I think I showed you in a few of the figures that I showed both in Paloma and Papillobes, the chance of a spontaneous. Fernanda also told us in the very first slide, the chance of a spontaneous regression of a CIN1 lesion is high if you look at it globally in the whole population. But there still is a chance of persistency. There's still a chance of progression, and always take into account that we are talking about not doing anything and expecting an spontaneous clearance within 2 years. Let me ask you a question now. Do your patients feel comfortable with the idea of waiting for 2 years without doing anything, but just quitting smoking or whatever? The answer is no. So for us, if we're able to accelerate this clearance rate, improve this clearance rate, and within 6 months have the patients free of cervical lesion and HPV cleared, I think it is a good idea. At least we should feel comfortable enough to offer this possibility. If you do it or not, it's up to the patient, obviously.
Then a question, Fernanda, for you. This is a general question that we have in clinical practice. The question arises from Maria Grazia Arena. What do you recommend if a 32 years patient with low-grade SIN wish a pregnancy?
To get pregnant.
Fantastico, absolutely.
With a previous colposcopy.
With a previous colposcopy.
Yes, previous colposcopy and follow-up also, but to become
But
pregnant.
go for it for sure.
Yes.
Absolutely. Then from Michelle Samaha, thank you for this elaborate presentation. Is there any difference in the management of low SIL due to HPV 16 and 18 and the other non-HPV 16, 18 genotypes?
With a low-grade lesion, he said?
With a low-grade lesion. I think on the possible evolution to be 16, 18, but to have a low-grade lesion, or to be another type and to have a low-grade lesion, this give a different destiny?
In terms of guidelines,
yes,
management is exactly the same. In terms of what we should be expecting,
yes, it is different.
It is different. It could be different. So we know that 16 is the worst scenario possible. So and all of the publications go in that direction. So we know that it's a lower chance of clearing the infection if 16 is around.
Then Anna Consalves, this is also a nice question. What would you recommend in a postmenopausal woman with high-risk HPV, pap smear, ICIL type 3 transformation zone, and endocervical curettage with low SIL? In a postmenopausal women with high-risk HPV.
And high SIL means that is a cytological result, or that's a biopsy?
I think I cannot tell you, but I read the question.
Okay.
Put the difference. Tell why you make that question. Why you make that question? Because there is a difference. Go on it.
Clearly, if that's a biopsy, if that's histology, then the answer is very clear. High risk, high grade lesion with biopsy, conization is the treatment that we should be going for, clearly. If that's a cytological result, then colposcopy should be performed. If with a colposcopy, there's a different result with what you're seeing and with the result of the test, that's when we have trouble.
That's why I think that was the question, because she says endocervical curettage with a low-grade lesion.
I assume that if colposcopy is normal and she's performed curettage in the endocervical area, then we could be safely conducting a wait-and-see attitude, I think. Would I bring this woman to a yearly basis study? No way. No. I wouldn't feel comfortable, because I strongly think that there's very likely something going on in that exothermics and that we're not seeing with the colposcopy.
Yes. This is one of the cases that the American guidelines admit to do immediate treatment without a colposcopy. We always do a colposcopy, okay? But the American ones tell us that when they have a high-risk HPV infection with a high-grade cytology, there is a risk of immediate SIN3 plus is 60%. So they considered that is correct if we want to do treatment. Okay, but I will do always the colposcopy, and I will follow not after 12 months, but maybe 6 at least.
And then Virginia Serbu, she's making another question. If the patient is vaccinated and now is HPV positive with another type of HPV, do you recommend papillocare?
If the patient is vaccinated, yeah, clearly.
Yes, but she was vaccinated, but she have another. She's another HPV which is not included in the vaccine.
And if she had if she had one of the vaccinated genotypes, even more. So I'd say always yes.
Always yes. Always yes. Absolutely. Okay. And then okay, we are approaching to the end. Okay. Another anonymous asking, is HPV vaccine feasible for HPV 16-18 positive patient with negative cytology and normal colposcopy picture?
Is always feasible, I think.
Yeah, has nothing to do. That
That's
the
the
vaccination
message.
indication doesn't depend on the results of HPV testing, of sexual behavior, or cytology.
No, have to be done to everybody. And also I suggest also in males, and have to take attention to that one. Okay. To have then that one. Is it possible to have sexual intercourse during papillocare therapy? Certainly, yes. Why not? Please.
Yes. The answer is yes. We didn't see any difference whatsoever, and that's something that we ask in our patients in the whole information that we recovered in the Paloma trial. That's something that we had to ask, and obviously there was no contraindication, and there was no changes in what we saw in terms of effectiveness of the treatment.
Thank you. And then another general question, Fernanda, probably you can give the answer. How HPV lesion and the proposed treatment with this gel may influence fertility or IVF treatment?
The gel could, I don't, can you repeat again, please?
Yes, if the HPV lesion and the proposed treatment with this gel may influence fertility or IVF treatment, then each HPV lesion can affect fertility or IVF treatment?
Some studies now note some connection with an HPV infection and the results of IVF, the quality of embryos, and so on. Okay, it's not my area, but there are some connections between HPV infection and the obstetric results. Yes.
Mostly
So
also
probably related to the microbiome.
Yes, microbiome,
Probably,
and also related to the activation of inflammatory aspects of the vagina, because this also can change the capacity of. Okay, then. Okay, then 1 second, I will go, Victoria.
A lot of questions.
Okay, a lot of questions, Victoria. It is rational to vaccinate women after 45, or for example, we can use papillocare gel. Why not both of them? Please, can you have a comment if the fact that vaccination have not to be given only on an age-related problem of the woman?
I think Fernanda and myself will say exactly the same. Go for vaccination. No one said anything about age. Just go for it. I mean, and please, it's very important for us to make this very clear. This is not a matter of choosing one way or the other. This is not a matter of choosing vaccination or treating low-grade lesions with a vaginal gel. This is a matter of protecting our patients. So protecting means prevention. Prevention means vaccination. But even in the scenario of vaccinated patients, which we had in papillomas, if they have a lesion, if they're HPV positive, go for the treatment.
Yes. And then, okay, we are approaching to the end. I would like just to read that anonymous with thanks and ask you, Fernanda, do you recommend papillocare for persistent HPV and normal cytology and colposcopy?
Yes.
Yes, this I thank you very much. Okay, Then okay, then I would like, now we are approaching to the end, I would like to have, I will read the last one. Do you recommend the use of condoms during treatment with papillocare gel in order to potentiate the HPV clearance probability?
Every time that we have an HPV patient, what we will counsel our patients is trying to avoid further exposure to HPV or to whatever other disease.
Yes, to whatever.
Using condom is the best protection possible.
Thank you very much. Okay, then I think we are at the end also for time. I would like, it was a fantastic webinar, which touching really something fundamental for our daily practice, what to do, how to manage for an infection, which is not something who can touch only a small percentage of individuals, who touch at the end of the story the majority of women having sexual activity during their life, and also the majority of males. Then I would like to have a final comment. We started with Fernanda and we terminated with Damian, you were the second one. Then I would like to start, Fernanda, please, on the basis of what you have done until now in your studies and your activities and your observatory, you are looking from your clinical practice, looking what happened in the world. What are the suggestions that you can give to a young adolescent or post-adolescent woman, girl, who approach to her sexual life, knowing that she will probably have a pregnancy 20 years after and even more, and then she have to try to maintain as healthier as possible her reproductive tract? Then Fernanda, and then later on I have another question, Damian, for you.
My advice will always be to a younger lady to have healthy lifestyle, reduce number of sexual partners, explain to her that sexual diseases is not only HIV, talk about chlamydia, the HPV. We have to talk about all that, because at least 80% of all have contact with an HPV infection. We know that most of this infection will be cleared, but we never know when they will persist and what could lead for. And that vaccination is essential. So in Portugal, she will be vaccinated if she's Portuguese and included in the national program. But there are a lot of other types of HPV that are not covered by the vaccine. So we have to maintain our healthy lifestyle. I think this is a message that all doctors should give to our patients, I think.
Thanks a lot, Fernanda. And then now I would like to go to Damian. Damian, now I would like to ask you on the other side of the moon. We are now making treatment. As you know, I have just published the position paper from FIGO on benefit and risk of hormone replacement therapy 2 weeks ago in the International Journal of Gynecology. And then I would like to speak with you. We are treating women to maintain hair femininity until very, very, very advanced age. Then after menopause, for the prevention of not only of the cervical cancer, but also for the prevention of all those kind of cancer who can be related to papilloma virus in different types, in different organs. What is your suggestion for women who are already after menopause? They were young when the vaccine was not existing. Remind that one, they were young. What do you suggest to a woman who, by her treatment, she wants to maintain her femininity and also the pleasure to have a satisfactory sexual life?
Yeah, tricky question again, but here in Spain we had a publication, an old publication called the Estudio Afrodita, in which we saw the changes in sexual behavior in Spanish women, and we saw how nowadays older women are having behavior clearly more similar to younger women. So that in a way exposes all of them to all of these diseases that we've been talking about. So vaccination against HPV, does it make sense? To me, clearly. Using condom, tell your patient, tell your 60 years old patient to use a condom. Well, obviously she'll say that she doesn't need it, But nowadays, we're seeing changes in their behavior. So if they're behaving like younger women, and I know that this is stupid to put it this way, but if they're having a sexual behavior that puts their health in risk, we should be counseling exactly the same way as we're doing with the younger patients. So there's
Thank you, thank you. You know, I think that we have no limit of yacht now, no limit done by the treatments. And women once in the time, sexual life was completely lost after the menopause. It was some natural destiny. Now, with treatment and also with the stimulation from the society, sexuality can be maintained. Then, dear ladies, you have to take care of yourself, as Damian Dexeus was telling us. And young girls, you have to take care of yourself, as Fernanda Santos was telling us. And it was a pleasure to be with you. And on behalf of the European Society of Gynecology, I thank ProCare Health for supporting our event, and I thank Fernanda Santos and Damian Dexeus for the beautiful lecture, full of science, but also full of humanity. And then, dear friends, thank you very much. Enjoy your life. Take care, stay healthy, and remind that we have always to solution for our problems, and science is growing up and developing up. And then we thank these beautiful scientists to have participated their knowledge and their clinical capacities with us this evening with the webinar of the European Society of Gynecology. Thank you very much.